presentation. I know and appreciate everybody coming in the afternoon to listen to our talk. I'm going to be as quick as I can. I'm going to talk today about orbital and intracranial complication of rhinosinusitis. So I'll start with some basics and try to concentrate on a few topics for our trainees for their exams. We're all familiar with the definition of acute rhinosinusitis. It generally starts as viral, and if symptoms increase after 5 days or persist after 10 days, it's then considered post-viral acute rhinosinusitis. The incidence of acute rhinosinusitis is actually high. In adults, it's between 2 to 5 per year, and in children between 7 to 10 times per year, while the incidence of bacterial rhinosinusitis is between 0.5 to 2%. Next slide, please. So it's important to know when sinus pneumatizes, and this diagram will help us understand this. At birth, only the maxillary and the ethmoid sinus are pneumatized. Sphenoid pneumatize at 9 months, and the frontal sinus are the last paranasal sinus to pneumatize at age 6. Pneumatization of the frontal sinus is not visible, right?
Can we make sure that everyone can see the presentation?
Yes.
I think we're one slide behind, Abdurrahman.
Okay. So
we're slide number 3.
Yes, start the one. If you don't mind, just when you say, just tell me to next.
Yes,
so
I'll give a prompt.
Yeah, sorry.
So we're just talking about the sinus pneumatization here. And I just mentioned that the frontal sinus is the last to start pneumatizing and that age, around age 6, and you won't see it radiologically before age 7. And all sinus continue to pneumatize until adult life. Now, next slide, please. Now, with this behind us, let us discuss the main topic of the day. So the European position paper in 2020 classified complication into what you see in orbital intracranial osseous, and we can see that the most common one is the orbital complication. We'll talk about some of them in a bit detail. Next slide, please. The incidence of orbital and intracranial complication is about 3 in a million, and there is a male predominance. And the predisposing factors in children is acute bacterial rhinosinusitis, and in adults is chronic rhinosinusitis. And it's important to understand that oral antibiotics do not provide advantage in preventing the complication in the form of intracranial complication of sinusitis. Next slide, please. When we talk about orbital complication, you probably heard the term preseptal and postseptal, but what exactly is the orbital septum? The orbital septum is a fibrous layer arising from the periosteum of the orbital rim. It lies directly behind the orbicularis muscle. It's an anatomical boundary of the lid. It separates the eyelid from the orbit and separates the intraorbital fat from the eyelid fat. And it provides a barrier against spread of infection between what we call the preseptal and the postseptal space. Next slide, please. So Chandler divided the orbital complication apologies into 5 groups. And like most classification system, Chandler's classification is not perfect. So group 1, which we call preseptal cellulitis, is not really an orbital complication. It's merely an eyelid facial infection. And type 5 is an intracranial complication, which is the cavernous sinus thrombosis. And it's not an endpoint of orbital complication, meaning not every child with an orbital complication will end up getting a cavernous sinus thrombosis. Next slide, please. So what are the offending sinuses in order of frequency? The ethmoids are the most common one, followed by the maxillary, the frontal, the sphenoid, and the host of organism. It depends where you are, but generally in the Western world, we have the Streptococcus pneumonia and malaria, the Haemophilus influenza, and Moraxella catarrhalis. We'll talk about the mode of spread, but in general, either dehiscence of the lamina papyracea or through the valvulus veins. Next slide, please. Preseptal cellulitis is type 1 or grade 1, and again, remember, this is just facial swelling and inflammation. It's an eyelid edema. erythema, pain, and fever. There is no visual impairment, and there is normal movement of the muscle. And generally, we don't see kids at this stage. Their parents think they might have an allergic reaction to something or an insect bite. But the next stage, next slide, please. This is what we generally see, orbital cellulitis. There is edema and inflammation of the soft tissue, but there is no pus formation, and there is no vision impairment, and there is a bit of decrease of ocular muscle, and that's due to the swelling and edema, and there is some proptosis and chemosis. And then it gets a bit more interesting. We get the subperiosteal abscess stage. And here there is pus collecting between the periorbita, which is the periosteum, and the bone. And you can see from the scan that the orbital contents are displaced, usually in an infraorbital, in an infralateral direction, but that depends on the site of the abscess. In these cases, there is certain limitation of ocular movement, which we call ophthalmoplegia, and there is impaired visual acuity, although that can be detected later and not necessarily early in that stage. But generally, this is an alarm bell for us. Next slide, please. The following step is when we neglect the orbital abscess and we get rupture of the subperiosteal abscess, we get complete ophthalmoplegia and very, very potential reality of visual loss. Next slide, please. This is a patient with cavernous sinus. It's an intracranial complication, not an end result of orbital complication. And the hallmark of it, next slide, please, is that it has bilateral ocular symptoms. So patients remain with high mortality despite the IV antibiotics and anticoagulants, which were a bit controversial until recent, but every neurologist now uses anticoagulant. They present with severe headache, periorbital edema. Symptoms are bilaterally, so this is not an orbital complication, which is usually unilateral. That's an alarm bell. Then the cranial nerves that pass through the cavernous sinus get affected. Cranial nerve number 3, 4, V1 and 2, and cranial nerve number 6. There's also loss of corneal reflexes, ophthalmoplegia, papilledema, and visual loss may result from the obstruction of the retinal venous return. Next slide, please. Okay, so I'm going to talk about a couple of clinical scenarios. So for our trainees, you may be presented with a picture like this, a 7-year-old girl with swollen, tender left eye. And I'll say the eye is closed with some obvious proptosis. And I'll be asking, describe your management. So you'll start by saying something like, I'm concerned that this is a vision-threatening emergency and it's best managed concurrently with an ophthalmologist. So bang, if you say something like that, you're already on the winning books because you have identified that this is an urgent emergency. And you'll continue saying something in the form of, I'll take a history focusing on recent upper respiratory tract infection, the duration of symptoms and treatment, and ask about pain and movement of the eye. And if the patient can move their eye, I'll check for chemosis and range of eye movement. I'll also pay particular attention to focal neurological signs. Again, winning point, the examiner now knows that you're thinking in the right direction. And we'll talk about that in a minute, such as headache or reduced conscious levels. I will start IV antibiotics, nasal steroid drops, and nasal decongestant drops. I will arrange for an immediate ophthalmology review. Next slide, please. Okay, so the examiner may say, you mentioned neurological signs. What we'll be looking for, you know, the answer is non-specific fever, lethargy, or central neurological findings like hemiparesis or seizures. So you get your ophthalmologist to have a look at the child. The next question is, what do you expect the ophthalmologist to assess? You need to know that they should be looking for visual acuity and color testing. What are they using? They're using the Snellen and Ishihara test. They're going to check for intraocular pressure. They're going to check for the afferent pupillary defect, which is when the eyes when one eye is exposed to light, both eyes react in the same way. If there is a defect in one, then there is a pressure on the optic nerve. And they're going to measure the proptosis. And this is measured by an exophthalmometer. And it measured the distance between the lateral orbital rim, the bony rim, and the front of the cornea. And in general, it's about 10 to 21 millimeter. And it's equal on both sides. So if there's an increase of about 2 millimeter between the eyes, this is an abnormal. So this is how they measure the proptosis. And they're also going to measure for the test for the extraocular muscle. Next slide, please. Okay, so you get this scenario where the ophthalmologist is unable to examine the eye, not available. Like in our case, they cover 2-3 hospitals at a time. Sometimes they're not available to see your child. So what's your next step? How would you image this patient, and what modality would you image, and what's the indication for imaging? So your answer would be like, if the ophthalmologist is unable to examine the eye, I will arrange for an urgent CT with contrast. And if I suspect intracranial complication, I will also arrange for an MRI. At this stage, you're actually flying through because the examiner knows you're safe. Can we have the next slide, please? Do you see a CT scan now?
Yes, I can see this.
Okay, perfect, thanks. Okay, so the next question would be, tell me what you see. So your answer is that this is an axial view of a CT scan of paranasal sinus and orbit with contrast, showing left subperiosteal abscess displacing the orbital content laterally. And the indication for imaging is, as we've just answered that now, inability to assess the vision. There is proptosis and ophthalmoplegia. There is bilateral edema, because this is most certainly cavernous sinus thrombosis. There is deterioration of vision and lack of improvement after 24 hours of IV antibiotics, and we'll touch on that. Next slide, please. Okay, so how to manage this case now? And is there a role for IV antibiotics? And is surgery indicated? Can you describe your approach? I would manage this case surgically, and although there is evidence to support the use of IV antibiotics in early subperiosteal abscess with a collection of 0.5 to 1 milliliter in young age groups, this particular case, there seems to be a large subperiosteal abscess necessitating urgent drainage. And really the approach, there is no right or wrong answer. It depends how confident you are with your endoscopic skills. So if you're confident with your endoscopic skills, then endoscopic approach, and that will entail uncinectomy, middle meatal antrostomy, and isthmoidectomy. Or you can say, I will use an external approach. It would be straightforward in my hand. And I'm aware in specialized pediatric center, endoscopic approach is frequently used. And I will perform Lynch-Howard's incision. And you need to familiarize yourself with each approach, pros and cons. Next slide, please. So how do you perform Lynch-Howard's incision? Following local anesthesia, you'll make a curvilinear incision halfway between the medial canthus and the nose down to the periosteum. And you identify the solid lacrimal bone. Posterior to it is the very thin lamina papyracea. Use a pole probe or what do you call it, a 3'rd elevator to flick the bone and release the pus and insert the drain. Next slide, please. Now we'll talk about the intracranial complication, which represent about 15 to 20% of patients. And the mode of spread is really a couple of ways. One of them is the valvulus diploic veins. And we need to note that the flow of blood through the diploic vein is at its peak during teenage years. And as the frontal sinus continue to pneumatize, remember, it starts at 6 years of age. So at teen adolescence, they start developing bigger sinuses, and blood supply is very abundant there, and they develop, they pass this thrombus through the deep venous, to the dural venous sinuses. It can also go through the extensions through the sinus wall or spread through the posterior wall dehiscence. Next slide, please. The signs and symptoms of intracranial complication, we're not going to talk about them, but we know they can be non-specific. But most importantly, we need to appreciate that they can accompany the extracranial complication at the same time. And there is a significant number of patients, between 40 to 60%, who would have intracranial complication, but there is no neurological signs. So vigilance is important. Next slide, please. Studies will tell us that patients 7 years and older with orbital infection have been shown to have 10% chance of concomitant intracranial involvement. And CT must be requested with a contrast, and it may not detect the intracranial complication. And if you have any suspicion, an MRI is safe. Next slide, please. This is a scan of one of my patients. Is a child with right orbital abscess and right subdural collection that required emergency craniotomy and endoscopic sinus surgery. And you can see that the abscess is lateral, so I needed to do an external incision as well. Let's move to a different patient of mine. This girl, she's 11 years of age, transferred to my service with 4-day history of lethargy, fever, and forehead swelling and vomiting. So the question would, for the trainees, would be describe what you see. So you say something like, this is a sagittal CT with contrast showing opacity of the frontal sinus with soft tissue swelling over the frontal bone with a small frontal dural collection. And I'm very suspicious of Potts-Puffy disease with intracranial complication. And how would you manage this? We'll be answering something in the form of, I'll take a history focusing on upper respiratory tract infection, duration of symptoms, any previous treatment. I'll pay particular attention to any focal neurological signs, headache or reduced conscious level. I'll start immediately IV antibiotics, nasal steroid drops, and nasal decongestant drops. And I'll urgently consult a neurosurgeon and arrange for an MRI brain with contrast. And next slide, please. So the neurosurgeon reviewed it, and he said, I'm happy, I don't need to intervene. What's your treatment plan? This patient will require urgent frontal sinus drainage in the form of frontal terrifying, which is more straightforward. Again, no right or wrong answer, but you should say that I'm aware that in specialized centers that can be dealt with endoscopically. In this particular instance, what I did is a draft 2 frontal surgery. And a repeat CT scan showed the resolution of collection, and hence there was no need for a neurosurgical intervention a day or 2 later. And that patient was discharged well on 6 weeks of IV antibiotics. Next slide, please. Okay, what do you do in the absence of terrifying sets, which were produced by Medtronic, but they are not in the market for the last 3 years now? So we go back to our old techniques. We inject the medial aspect of the eyebrow with local anesthesia, and we make a 2 centimeter curvilinear incision below the eyebrow, try to avoid the hair, down to the periosteum, and we use a drill on the inferior wall of the anterior frontal sinus plate. This part is the ploic. Open the sinus mucosa and drain it, and wash the sinus and insert the drain. Next slide, please. And while we're on the topic of frontal sinus, I just want to briefly discuss the draft surgeries. So drafts have 1, 2, and 3. Draft 1 is not really a surgery or affecting the frontal sinus. It's really more of a concept. This procedure consists of an anterior isthmoidectomy for drainage of the frontal recess without dissecting the frontal sinus outflow pathway itself, meaning it involves the removal of obstructing disease inferior to the frontal sinus recess. What do? We chase the anterior superior ethmoid cells, including the agar nazi, and we resect them so the outflow is clear, but we actually haven't touched the frontal sinus outflow. Next slide, please. So for draft 2, there is A and B. In A, this procedure entails removal of the anterior ethmoid cells as type 1, and also the frontal cell protruding into the frontal sinus outflow. And by doing this, we create a space or an opening between the middle turbinate medially and the lamina papyracea laterally. And by doing this, we enlarge the frontal sinus outflow. Next slide, please. So I'm just showing here an example of doing draft 2, and this is not really in an inflammatory case, but this is a case of an inverted papilloma affecting the frontal sinus, and I wanted to have access to the frontal sinus using a 0 degree for future follow-up in the outpatient. So I use this, it's an Australian technique called Caroline window. Abdurrahman, can you play the video, please?
The video is on, yes. So,
oh, sorry.
So we are at the drilling area.
Oh, okay, so
yeah, so elevated the flap, and then we
are.
So
I'm just going to say creating the inferior base flap. I started at the roof of the axilla and find my way to the piriform aperture and create the inferior flap. And then I use a drill to drill what's used to be the axillary flap. P.G. Wormald called this an axillary flap. So instead of taking away the anterior wall of the agar nazi, I removed the frontal wall of the axilla, identify the skin or the periosteum, and keep drilling. It's an aggressive drilling, to be honest, and stay lateral to the middle turbinate axilla, because that's where the olfactory fila are and the skull base, until you achieve clearance of the frontal recess. And that will allow you to inspect the frontal recess using a 0 degree. Next slide, please. The draft type B consists of removal of the frontal sinus floor between the nasal septum and the lamina papyracea. And by this, you're creating a large opening of the frontal sinus outflow. Draft 3, bilateral removal of the floor of the frontal sinus from one lamina papyracea to the next. And that's called modified Lustre procedure. And this is just a CT and MRI showing brain abscess due to an intracranial complication of frontal sinusitis. You will often hear people talking about cranialization. And if you have a neurosurgeon who performed cranialization due to a brain abscess coming from the frontal sinus, there is no need for you to intervene anymore, because what happened there is that they allow the brain and the dura to move forward and fill in the space of the frontal sinus. They block the connection between the frontal sinus and the nose, and they rest the brain and the dura over the repaired anterior plate of the frontal sinus. So they fill the space with brain and dura. But they have to take the frontal sinus mucosa and close its access to the nose. Next slide, please. So briefly on the above, we know that intracranial infections are uncommon but potentially devastating complications. The diagnosis and management are challenging and require close collaboration, and that's very important between an otolaryngologist and neurosurgeon and infectious disease. And be vigilant for silent intracranial involvement, particularly in children. Have high index of suspicion. And I would like to draw your attention to a paper we published between Temple Street Children's Hospital and Beaumont Hospital regarding the intracranial complication of sinusitis and acute otitis media. It makes for an interesting read, and we basically always involve the neurosurgeon to drain the abscess. We do endoscopic sinus surgery in the vast majority of those cases, and to get the IV PICC line before they go home. Now I'll move to the adult complications, and I'll just going to show one of our cases, the osteomyelitis. So this is a patient of mine. He is a cystic fibrosis patient, and you know how complicated sinus surgery in these patients. He presented with a recurrent infected right frontal mucocele, developed later on to osteomyelitis of the frontal bone. I initially managed him with draft 2 and then ended up going for draft 3, but it went beyond that. So this is a stenosed draft 3, 16 months after with recurrence of symptoms. Can we play the video for this one? So here I
don't have a video.
Oh, sorry. Okay.
This is a frontal. I have pictures only for
Okay,
the
so that's okay.
frontal.
So what I did again is replace the anterior frontal sinus wall with calvaric bone graft because I suspected that the bone is very inflamed. And if we had looked at the scan, can we go 2 slides back? Just you can see the CT scan with dehiscence of the upper orbital wall, and there is thickening of the bone on the right side that represented osteomyelitis. Okay, we'll go back 2 slides, down 2 slides, thanks. And I drilled the frontal draft 3 again and ended up with bicoronal flaps. Used a piezo, which is very gentle harmonic device, does not affect the soft tissue. It only can work on the bone. So it was safe to work with it around that area. Next slide, please. Here, the diseased bone was removed and replaced by a split thickness calvareal bone. Next slide, please. And the calvareal bone is diploic, so the outer plate can be taken easily and replace the osteolytic bone. Next slide, please. And then plates and screws. And that patient is doing very well almost 2 years after. Now we're approaching the end of our topic really because I appreciate people are tired. So one of the very catastrophic complications is an invasive fungal sinusitis. It's caused by mucormycosis, rapidly progressing and very life-threatening fungal infection. The chance or the incidence of it is 1.7 in a million, and most of us would have seen 1 or 2. I consider myself lucky. I've seen 3 cases in my career, 2 adults and a child. It affects people with immune compromised generally, and inhalation of the spore comes from decaying grass or leaf mold, and it can affect multi-system. The hallmark of it, next slide please, is angioinvasion. So the invasive fungal you literally see black tissue, and that should raise your alarm immediately. The spores germinate into hyphae into the sinus, and they spread via the vascular and neural channels towards the orbit and the cranium superiorly, and towards the maxilla inferiorly through the foramina, and then through the blood to the bone, the cartilage, the nerves, multisystem, and fatality is very high. So you need to be aware of it. You need to be making a diagnosis immediately. Do not wait for culture. You start antifungal therapy, generally amphotericin B and posaconazole. Aggressive surgical debridement, and if the eye is affected, you have no choice but to take it, and you have to control the underlying medical condition. Next slide, please. A recent interesting paper from India discussed over 200 patients with rhino-orbital cerebral mucormycosis during the second wave of COVID-19. This is a massive number for anybody to see in a lifetime, but it's very interesting to read. And that brings us to a close. Thank you very much.
Thank you, Mr. Amin. Really interesting presentation, and thank you for your time. Anyone have questions? I will start by myself as well. It's about the draft to BE technique. So you do inferiorly based flap, but you dissected it anteriorly. You don't do it retrograde, so not from inside with the design.
That's the 2A.
Yeah. For the 2A, sorry.
Is released inferiorly to replace it later on. You start as if you're doing a loss from lateral to medial, keeping the middle turbinate axilla in view, so you don't cross that line. And on your way in, you're going through the frontal recess opening and the agar-nazi wall, and you drill the agar-nazi anterior and posterior wall, and then you have a straight, direct vision into the frontal sinus.
My question was, is it from inside outside or from outside inside? You drill, your handling of the drill, is it from inside outside?
From inside to outside, yeah.
This is my question, that's fine. Yeah. The second question from my side as well is about the MRI scan for the children. You said that the incidence of the intracranial is more higher, but would you think that because the intracranial complication is higher in the children, MRI scan is better than a CT scan, or we have to follow what's the faster is an emergency, this CT scan? This is a question of an exam as well. Yeah, so it depends it really depends on the facility you work in and the time of the day that the child arrives. Like in Temple Street, which is one of the two main hospitals in Dublin, they will not do an MRI scan in the middle of the night. They'll do a CT scan. So you need to talk to the consultant and express your concerns, clinical concerns. So in a child above 7, if you feel the child had a CT scan and there's no intracranial complication obvious, but your clinical guts tell you that this child is more sick than you would expect, then I'll challenge any radiologist who won't come in the night and do an MRI scan. So the neuroscience is very important. So the neuroscience is very important. Age is very important, and your holistic approach to the child himself. So I would say it's a clinical sense of how sick is the child and what is the neuroscience of this child. Yes. The third thing is the involvement of the neurosurgeon. Do you think that the neurosurgeon are the people who have to step in first, or the ENT and then the neurosurgery, or is it a way be same time operation, so 10 act, or meter act, which is and then so we had this discussion, and that's the reason we published this in conjunction with the neurosurgeons. So the agreement is that we should be there at the same time, and ideally before the neurosurgeon is needed. So if we intervene early, the chances of developing intracranial complication is less. But if there is an intracranial complication and sometimes the child arrives to the neurosurgeon before us, referred straight to the neurosurgeon for intracranial complication, and they find that the reason for it is a sinus or an ear infection, we arrive at the same time in the same theater. The thing is whether you go before them or they go after you, that really doesn't matter, because both procedures are fast and quick. But we endeavor to be in theater at the same time, day or night, with the neurosurgeon. If this is a question of an exam, we have an evidence is your publication. Yes, and it's a multi-center publication with a couple of neurosurgeons, a couple of ENT surgeons. I think it should stand. That's fine. So at least everyone search for this paper. So it would be your evidence when you're talking of the simultaneous action between the neurosurgeon and the ENT in the same time for the management. Anyone wants to ask questions before closing the session today?
was short and nice. And also as usual, please everyone write his email to in the chat area so we can send you the certificate for the attendance. And sorry for any spelling mistakes. I'm doing everything by myself, so I'm the one who record, invite the people, and also send the emails. So sorry for this. If there's any kind of spelling mistakes or any inappropriate timing for the for also these sessions.
Ibrahim, I think you're doing massive work. Massive work. I'm following your meetings and courses. I don't know when do you have the time to do all this? Well, fair play.
I'm trying my best. I have also a nice team that's help sometimes.
Absolutely, you must be.
Thank you, Mr. Amin. Again, you're one of the eminent rhinologists in Ireland as well in Europe. Thank you for this time. Much. We know your value of time as well.
Thank you very much. Appreciate it. Take care. Bye.
Bye.